detailed. Okay, I'm Emily. I'm a fourth-year pharmacy student from the University of Iowa College of Pharmacy. Well, along with a classmate, we looked at the impact of acute migraine treatment on emergency department length of stay. So, migraines are really common, obviously. A lot of times we treat them with triptans outpatient, but actually inpatient we commonly use antiemetics. So in some head-to-head studies, metoclopramide and prochlorperazine have been found to be superior to sumatriptan. So our study basically just looked at the use of antiemetics, especially
Peridol, metoclopramide,
prochlorperazine. Things like that. And so yeah, so this was a retrospective cohort study.
Okay.
We just did a chart review. And we just looked for the time to discharge after the administration of medications. So at first we were just going to look at metoclopramide and prochlorperazine, but there was a really big use of droperidol back in 2012, when that was when we started collecting data. So we included them too because we had enough for our sample size. And then we looked at some other secondary outcomes, like how many doses we needed, time to readmission within the next 14 days, and then just things like that. So people were included if they had a chief complaint of migraine, and if they received one of the 3 antiemetics that I talked about earlier, and they were excluded if they were pregnant, if they got admitted, and if they had a diagnosis of something else. So our results, we found that droperidol was statistically significantly shorter duration of stay in the emergency department. Droperidol versus prochlorperazine and then versus metoclopramide head-to-head, both were significant. But when we look at prochlorperazine and metoclopramide together, they were about the same. Need for second doses, metoclopramide significantly needed more doses than droperidol and prochlorperazine. And then the need for other rescue medications and readmission rates within 14 days were non-significant. Just some demographics. Most of them were female, around the age of 40, plus or minus 10 years. And then we did look too at the use of abortive medication. So if they came in and said they took a triptan or took ibuprofen, something like that. And then the use of preventative medications, beta blockers, calcium channel blockers, topiramate, things like that. And those were all really similar across groups. So discussion, the administration of droperidol resulted in a statistically significant shorter duration of stay in the ED. And then patients needed more doses of metoclopramide compared to the other medications. Droperidol use after 2012 drastically decreased at the university due to a drug shortage, and then probably also because of its black box warning for cardiac toxicity. So it's actually really not used anymore. And we did have some limitations, especially for chart reviews. Some of them that we especially were thinking of was a lot of them were repeat offenders. We included people who came multiple times. So some people would come five, 6 times for the study. So when they come in, you know what they're going to get. They actually had a rapid Reglan protocol too in 2013. And with that, they were needing too many doses and they were finding it wasn't that efficient. And then we did have some problems too, like a lot of times patients were just, the only complaint they had medically was a migraine, and they didn't have any other comorbidities. And so on their medication list it said sumatriptan or topiramate or something like that, but we couldn't include it on the abortive therapy or the preventative therapy because they didn't say it to their doctor that that's what they took with their chief complaint. So our conclusion, while droperidol has the shortest duration of ED time, it's not really, I don't even think, we looked it up, I think that you can only get it, one manufacturer makes it, so it's really not available. And so it's great, but sorry. So patient characteristics also obviously should be taken into consideration when we're using stuff. Some of the side effects of some of the medications we maybe wouldn't want to use in certain patient populations. And then further studies are needed. Maybe we can optimize length of stay in different ways. Just in my chart review of some patients, some of them were started on abortive therapy or preventative therapy, so that could have gone, maybe that prevented them from coming the next time, or maybe it shortened the severity of their migraine, maybe they weren't having to come in any longer. So there were just a lot of things we could look into more to improve the speed of ED stay.
And first, when did the idea for this start? Or did you start P2 year, P3 year, P4?
It was P3 year. My co-student, actually, we took an emergency medicine elective, and she was just chatting with him because in class we were learning about headache. And so he's like, hey, guess what we use in the emergency department? And she's like, triptans! And then
no.
He's like, no! And so that kind of spurred that. And she works at the university too, so she had a working relationship with him. So then we got going on this.
If you start P3 year, I keep seeing that a lot of people get results. And if you start P4 year, sometimes the results aren't there.
Yeah.
So for somebody that's a student What do you recommend? Early P3, late P3?
Well, we kind of did. Actually, I think we were P4 in June to like 5 weeks ago.
Okay.
So I would recommend a lot sooner.
Earlier the better.
Yeah. Actually, at Iowa, they have a required component of their education now.
Okay.
They have to do. They get put in groups and they get a faculty preceptor.
Okay.
And so they actually just presented all the P3s presented a poster like this semester.
Oh, that's good.
Yeah, so
and
they're
then
like
you have to
dabbling.
get accepted though to someplace like ASHP.
Yeah. So if that's the way the pharmacy school works, then that's really
For the
easy.
new class,
For the
you have new class.
curriculum. But otherwise, I would just recommend reaching out to if faculty members. You can if you maybe like anticoagulation, you can ask them what they're up to, and a lot of people. I did some data collection for a resident last year, so you just have to kind of reach out and maybe find something that you're interested in.
Awesome. All right, thanks.